Welcome to 10 Daily Medical Questions. In this tutorial, we are covering everything you need to know about ACE inhibitors, one of the most essential drug class in cardiovascular and renal medicine. ACE inhibitors or angiotensin-converting enzyme inhibitors are widely used in the clinical practice and are indicated in several key conditions. Firstly, in heart failure, starting from NYHA Class 1, where they improve survival and reduce hospitalizations. Secondly, in arterial hypertension, particularly in patients with comorbidities such as diabetes or left ventricular dysfunction. And thirdly, after myocardial infarction, where they help in preventing cardiac remodeling and improving long-term outcomes. Now let's explore how they work. Pharmacodynamically, ACE inhibitors blocks the conversion of angiotensin I to angiotensin II by inhibiting the angiotensin-converting enzyme. This leads to multiple beneficial effects. They cause vasodilation by reducing peripheral arterial resistance, decrease sympathetic nervous system activity by lowering catecholamine stimulation, and reduce levels of aldosterone and antidiuretic hormone, leading to less sodium and water retention. This results in decreased preload and afterload. Additionally, by reducing aldosterone levels, they help prevent myocardial fibrosis and vascular remodeling. Bradykinin, which is normally broken down by ACE, is preserved, further enhancing vasodilation. These combined effects contribute to reduced cardiovascular mortality in high-risk patients and help protect against diabetic nephropathy. From a pharmacokinetic perspective, most ACE inhibitors are prodrugs, meaning they need to be activated in the liver to become effective. Notable exceptions are captopril and lisinopril, which are active drugs and do not require hepatic conversion. After activation, they circulate as prelates, the active form that exert therapeutic effects. The onset and duration of action vary. For example, ramipril has a half-life of around 48 hours, enalapril around 18 hours, and lisinopril about 24 hours. When it comes to drug interactions, clinicians need to be vigilant. ACE inhibitors increase serum potassium levels by lowering aldosterone. While levels up to 5.5 millimole per liter are usually acceptable under ACE inhibitors, the combination with potassium-sparing diuretics such as spironolactone, eplerenone, amiloride, or triamterene, or with potassium supplements, cyclosporine, or cotrimoxazole significantly increase the risk of hyperkalemia. Additionally, co-administration with NSAIDs can reduce the hypertensive effect and impair renal function. In diabetic patients, ACE inhibitors may potentiate the effects of insulin or oral hypoglycemics, increasing the risk of hyperglycemia. Also, when used with lithium, ACE inhibitors can increase lithium serum levels and potential toxicity. Combined with allopurinol has been associated with leukopenia, so monitoring is recommended. Regarding side effects, one of the most common and well-known is persistent dry cough, which occurs in about 5 to 10% of patients. This is due to the increased bradykinin and substance P in the respiratory tract. If the cough is troublesome, treatment should be discontinued and often switched to an angiotensin II receptor blocker. Other adverse effects include headache, dizziness, gastrointestinal symptoms, hyperkalemia, altered taste, proteinuria, and dysfunction of the kidneys or livers. More serious but rare side effects include cholestasis, skin rashes or exanthema, leukopenia, agranulocytosis, angioedema, vasculitis, allergic pulmonary changes, myalgia, and hypoglycemia in diabetics. Contraindications are very important to remember. ACE inhibitors must not be used in pregnancy due to the risk of ACE fetopathy, nor during breastfeeding. Other absolute contraindications include bilateral renal artery stenosis or unilateral stenosis in a single functioning kidney, a transplanted kidney, severe renal impairment, creatinine clearance less than 30 ml per minute, severe hepatic insufficiency, and aortic or mitral stenosis, as well as obstructive hypertrophic cardiomyopathy. You should also avoid ACE inhibitors in patients undergoing desensitization therapy, those with a history of angioedema or persistent cough due to ACE inhibitors, and those on immune suppressive therapy or potassium-sparing diuretics concurrently. Dosing. Dosing should always follow the principle start low and go slow. Begin with the lowest recommended dose and double it every 2 weeks until reaching the target of maximum tolerance dose. For instance, Ramipril typically starts at 1.25 mg once daily and can be increased to a maximum of 10 mg per day, either in 1 or 2 divided doses. Enalapril usually starts at 2.5 mg once daily with a maximum dose of up to 2 times 20 mg. Lisinopril starts at 2.5 mg per day and can be titrated up to 20 to 35 mg in a single dose. In conclusion, ACE inhibitors are cornerstone therapy in managing cardiovascular and renal diseases. They are life-saving drugs when used appropriately but require careful monitoring for renal function, potassium levels, and side effects. Their efficacy is reducing morbidity and mortality in patients with heart failure, post-MI, hypertension, and diabetes-related renal damage, makes them indispensable in clinical practice. Thanks for watching this tutorial on ACE inhibitors. If you found it helpful, don't forget to like, share and subscribe to 10 Daily Medical Questions for more high-yield medical contents. Stay curious, stay updated and see you in the next video.